Hello and welcome to SimCast, the Higher Education Simulation Podcast. My name's Lawrence Hill and I chair the simulation group in the School of Health Sciences at UEA Norwich.
Hello everyone, my name's Tony Jeremy and I'm the academic lead for simulation-based education at UEA Norwich.
In this episode today, we're joined by two fantastic guests and we're going to be talking about in-situ simulation in the UAE, in the Emirates Health Service.
You have to be careful with that one, that you don't get it confused with UEA, which is the acronym for our university.
Absolutely right.
If you enjoyed the episode, please give us a like. Equally so, if you didn't like the episode, give us a dislike, but let us know in the comments why, because we're always keen to improve. To keep up to date with all things sim, subscribe to the channel and don't forget to check the notification bell. And SimCast is available on all popular streaming platforms.
So today we are joined by Dr. Mohamed Nasaif. Thank you for joining us, Mohamed. Mohamed's an emergency medicine physician by professional background, but also a technology-enhanced learning and education consultant with the Emirates Health Services. Very warm welcome to the podcast, Mohamed.
Hi, it's a pleasure to be here, Lawrence, and Tony. Thank you for inviting us. So, as you mentioned, I'm an emergency physician by background. Most of my work now is with the Boubaker and the EHS Training and Development Center. My official title is Training and Development Expert. My portfolio is kind of a vague title. My portfolio is mainly technology-enhanced learning. So I work with Boubaker on simulation programs, and I also with the e-learning team on developing our LMS, and we have an in-house production team producing e-learning programs.
Thank you very much. And talking of Boubaker, I'd like to very warm welcome to Boubaker Ayadi-ben-latif. Thank you for coming and joining us from remotely from the UAE, the both of you. Boubaker is an ICU nursing specialist by background and an educator with a list of training accreditations as long as your arm. He's the education lead for multiple sites that the EHS run. And Boubaker, just introduce yourself and tell us a little bit more.
Thank you very much for giving us this opportunity. My name is Boubaker bin Ayadi-ben-latif. I'm a training and development specialist by job. I work with Dr. Mohamed since 2000, actually. We moved to these places together. I do run the simulation in the Training and Development Center, which is the biggest training center, mostly in the UAE. We have a lot of training sites. We have about 22 sites in basic one, and we have about 3 advanced training sites. We have a lot of educator faculty. It's more than 168 in basic, advanced, and educator and training center faculty, as well regional faculty, as well course director. We work as a team, and we serve the Emirates Health Services hospitals, primary healthcare centers. We train a large number a year, between 8 to 10,000 in all the disciplines. We have accredited courses from the American Heart Association, from the European Station Council, as well as in-house courses. We focus more on the simulation and practice. Our candidates are all healthcare providers, so they are on board. So we do upskill them with what is the updates and the skills and in the knowledge and everything together.
Right. And you've come fresh out of a simulation today, is that right?
Yes, we have daily courses, even in the weekends nowadays.
What have you been doing today?
Today we have 2 courses actually. One is the pediatric advanced life support. One is the advanced life support, which is cardiac.
Okay.
We have some nursing also training, but it's not simulation.
Fantastic. So I probably should say that Mohamed and I, we met when 2021, maybe 2022 at some point. We met first on a course that was being run at the University of Sharjah. That's how we first got to meet each other. And I was very pleased that Mohamed was kind enough to invite me to the training center where you're currently at right now, filming this episode of SimCast. So that's where the kind of connection originally stemmed from. But one of the things that we talked about when I was there was the fact that the EHS, the Emirates Health Services, which you're part of, and this kind of training wing, runs in situ simulation almost routinely, right, as standard, as part of what you do in the EHS. So could you tell us a little bit about the kinds of settings that you go into? Is it ED? Is it surgical? Where do you go into?
Right, thank you, Lawrence. I mean, it does feel like a very long time ago. Now thinking back, it's actually 2003, but it feels much longer than that for some reason.
Yeah, 2023, right.
Now, as you said, Boubaker is actually the lead also for the in-situ simulation. The history behind this, as he mentioned, we have 17 hospitals, 63 primary care centers, and several, quite a number of other different specialty centers, like dental, rehabilitation. All in all, we have about 140 facilities. To accommodate their needs, as Boubaker mentioned, we have our center here. This is the main hub for all the training, but we recognize the need to go closer to the candidates, especially we are quite distributed geographically. We have from Dubai, we have some activities, lab-based activities in Abu Dhabi, but most of our work is from Dubai all the way to Fujairah. For the international, this is more than 100-mile distance from our center to the Fujairah hospital, for example, and there are even more remote, smaller places. So to be able to serve people better, we started with basic satellites, and then we added after COVID, added three more advanced training satellites, and one is close to us in Sharjah, one in the middle in Ras Khaimah, and one far away in Fujairah, Emirates of Fujairah. But still, there was a gap. We do all this training, as you very much appreciate. We do a lot of simulation training, and we're not quite sure of does it transfer to the bedside. Do they do what they demonstrated successfully in our courses? And I think COVID kind of gave us a challenge, which had to make us innovate. We had to shut down our centers, but we had to do a lot more training to make sure that even people who don't normally deal with some of the respiratory acute cases to be able to do it. And that's where it all started. So 2020, March, April, March, probably March, yes. We had the shutdown and we just had to do something. And then with Boubaker's leadership, things developed further. We moved from just training and to assessing the readiness of the different facilities. Okay, we've done some training for them. There, as you described nicely, we have a distributed base of instructors, so they can also do some kind of training in their facilities. But with time, we want to make sure that training is effective and they are ready for the different kind of case mix that we were dealing with. So we focused on the COVID hospitals, and with time, we focused on a broader range of hospitals, primary care centers, just to make sure that they are ready to deal with the situation when they come to it. And then it continues. It was so successful. We got a lot of support from leadership. In fact, the Director General of BHS was very impressed with the program, and he supported that we continue even after COVID. So now there is a program that's running between all the facilities, mainly primary care and hospitals, to train and check readiness with the different places.
That's great. So a couple of things for me. Firstly, it's great that some of the things that you've had to innovate through being in a pandemic that have stayed and stood the test of time. I think that's testament
really
for
positive,
any
actually,
well-designed infrastructure that you've got. Also, just the infrastructure you've got, it's huge, isn't it? So I guess the next question for me is, how do you do it? How do you operationalize something that big? And do you have any challenges with it?
Well,
you need somebody like Boubaker.
It was an initiative, and we have a pandemic, and we need to go to the hospitals. So we have no other option. How do we go? Then we have our simulation high fidelity, mid fidelity mannequin. So we need to move from our training center, which was not possible for our provider to come to us due to the restrictions. Then we decided to move there, even though there was an issue of testing almost every alternate days and all. And we go to the hospitals. Then we request the hospital to give us what is their specific need at this time, at this acute phase now. What do you need? Each hospital has replied with a specific concern. Airway management, that was the big issue initially. Assessment, triaging, then dealing with chronic cases, all this. So we have set up a learning objective for each of the area we are going to visit with their needs, and then we have to develop a checklist, and we have to go there to their hospital, simulating scenarios and giving them the chance to practice in the which we call safe environment, because there is no blame in the simulation. But we do respect the time, because time is very crucial for us when you have an emergency.
Of course.
So we do the simulation in a real time, but with the concept of no blame. Then they really love it. And then some of the hospitals who are having priority, we mentioned that we give them priority. But later on, we got a request from all the sites, even from primary healthcare. And we need to go, and we even simulated donning the using the PPE. All what you expect was related to the COVID time. We have done it. We have even tried to utilize our clerk and our administrative people to do the triage with the people, and we have to provide them with the training. So we also call from the community to help the people in triaging outside the hospital. So from that time, we start, and we found this was very beneficial. So it's how do we move?
It's so interesting. It's so interesting. Just sorry to cut in, but like that. I guess my initial thought would be that there would be some fear of being assessed, some sort of sense of people being apprehensive about having you come. But people are contacting you and saying, please come to our primary health center, please come to our unit and run some simulation with us. So I'm just wondering, how did you communicate what you were doing with these health centers?
As I mentioned, we went there to do the required training by request first. So that was its training, and simulation is not checking the readiness initially. So we have to provide their needs. Then we have to close the gap they have it. Some people, they were in need for, as I mentioned initially, it was airway problems and management of the airway, ventilation, and all this. So we want to give training there, and we keep on doing the training until we are happy, as per the checklist we provided, that they are able to practice on a safe environment. So they like it, because they used to come to another place to move to have the training, but this time the training moved to them. And with the equipment, all the required equipment. So what we need from them is just specific time and a small area to make it free for us. And then we use and utilize our all mannequin, low fidelity, high fidelity, mid fidelity, and how we move to them. We have an ambulance, and we turn it to a simulation mobile unit.
That is amazing.
We painted as the simulation mobile unit. We put a logo on it. We come to you.
We need one of those.
We reach you wherever we go, and we put some branding. And we remove the color of the ambulance, so no one will disturb us on the roads. That we are not an ambulance, but we are trained.
Right. Yes, of course.
I think that's,
we kept the simulation as it is. Sometimes when we turn it from training to checking the readiness, we run with our mannequin. And we go to the ER. Good morning. Hi. We are from the Training and Development Center. We want to run some simulation. First of all, is it the time? We don't announce, because the patient will never say, I'm coming. He will just go like that. But we don't want to disturb the flow of the training of the real patient. So we say, if there is no emergency, we can proceed now. At any time you tell us to stop, we can stop and then start again. So they like the concept. So we are not pressurizing them. We are ready.
Very good.
And
it's interesting, Boubaker.
This is the free blame culture. We are here to support you. We are here to guide you. We are here to learn from you as well. So
do you
have
do you
the
think
right to do the mistakes now.
do you
And we are
think
here to
that
correct you. So the culture changed from being
Yeah.
tested to being evaluated without any fear. And
Yeah.
then they keep talking to each other, and then the demand was increased for us. And it was in
Right.
that terrible time, really, it was daily we moved.
yeah
So I was not able to cover myself, and I have to call some of my colleagues. And I highly appreciate their support. So we go sometimes in one hospital and we take two sections. One is going to do some area here in the general ward. One is in the
Very good.
emergency. And even I remember we did the how to do safe intubation during the COVID, and we have provided some barrier with the if you remember the house for the intubation, that box was the glass box. So it was everyone used to call us. So
Right.
really the start was quick, and honestly, the reputation goes up quickly. And then
so Bibi, can I just jump in here? So
Tony's absolutely itching to ask you
I've
a
got this
question.
question and I don't want to forget it. So you use a really interesting term, prepared for readiness. And I think going back to what Lawrence was saying, do you think that because we were sort of forced into this situation where we had to be so reactive to a pandemic, that everyone wanted to be prepared for readiness, they were a lot more accepting of you? Do you think if there wasn't a pandemic, you might have had different challenges?
We might go through different approaches. We might change our approach, and which we changed it later when the pandemic closed. We didn't stop the simulation. We will talk to that in the next few minutes. But the people, they like it because they found it's very helping. So, and if you remember, I'm so proud to say I work in UAE because they managed very, very, very well the pandemic time. With the COVID, there was less death compared to other countries. There is a lot of use of, let's say, ECMO devices in all over the hospitals. The transfer was very safe. The cooperation from the public, the cooperation from the police, the cooperation from all the departments, they work as one unified body in UAE. And this makes us so proud. And they call it, Mohamed, they call a group in UAE, and they used to text in the mobile everyone. We are proud of you.
Pride of the country.
The pride of the country. So
that's fantastic.
Support.
We're getting messages from leadership in the country regarding
Wow.
the support.
That's really impressive.
This feeling of support was there. There are a couple of points. I think you asked about Tony and Lawrence, which Boubaker mentioned. I really want to focus on them, just to transfer this experience to others. One is that when it comes to innovation and the ambulance, it was a really cheap transition for us. It wasn't expensive. The total budget was under $2,000. The reason for that is we found a kind of near retirement ambulance. So
decommissioned,
decommissioned.
Yeah.
It wasn't really decommissioned. It was there, but with kind of 3 tires out.
That's what a lot of the ambulance service in the UK is like, isn't it?
So it was running, but the air conditioning on the back was not there, so you know that no patient was being transferred. And so the course was really to just do the painting and rebranding. The equipment was from our training center, so we didn't have to buy any new equipment. And actually, I was curious to think if we didn't have this ambulance, we had to buy one. You can buy a second-hand ambulance, not suitable for human transport, for let's say 75,000 dirhams. That would be in pounds. That would be maybe 15,000 pounds or 20,000 less. Yeah, 20,000 US almost. So if we had to do this again with no ambulance to be provided, it still wouldn't be expensive compared to actually getting a ready-made mobile simulation.
Yeah.
And about the change management aspect, the idea of mobile simulation was there for quite a while. The pandemic was the opportunity to make it happen. Would we have resistance from the learners? Probably not so much, I think. I mean, you made us reflect on our experience again. We didn't think about it. it's nice to describe that we had like a linear thing. We did this, and it kind of magically paved the way. But like you could sense from Boubaker's description, there was a bit of going and coming, and so one success built on another success, and people asking, so we move on. One success is people were used to Boubaker and the instructors around the different facilities. Some of them are their colleagues in their own facilities. So the awareness of simulation, the importance of simulation, the impact of simulation was there amongst the users. Yes, I remember in the early days there were some people who Boubaker was saying they were not keen, like, let us see our patients, don't waste our time kind of attitude. But they were not the majority.
Yeah, very much.
And really that was overcome very quickly because people were used to the concept of simulation. And I'm proud to say we were looking at our numbers just a few days ago for last year. Simulation-based training is around 17, almost 18% of contact training hours for all face-to-face. So
that's
roughly
amazing,
speaking, which is quite, yes, exactly.
That's seriously impressive.
Mm-hmm.
And that must take it must take an enormous amount of faculty development as well. And that was one of the things that I was thinking. This project has clearly been a resounding success, and that's must be in part as a result of the experience of those learners, which is in part at the hands of the faculty who go and deliver these simulation events. So what faculty do you use for this, and how do you train them, and what have you learnt about the skills needed for in-situ simulation?
And the scale, how do you replicate that at scale and keep the quality?
Well, so we have a different instructor, let's say, and faculty from different disciplines, from the basic to the pediatric to the gynecology, the cardiac to the trauma. And each discipline we run in the TDC here, we have certified internationally certified instructor. Let's say the American Heart Association, we have about 70 of the instructors are basic life support instructor. We have about 20 or 25 in the advanced life support. We have about 20 to 25 pediatric and peers. Then we have some others certified with the European Resuscitation Council, like in the trauma course, European trauma courses. So then the newborn life support courses and the point of care ultrasound course. So those faculty, they are going through the renewal process as per the guidelines of the American Heart Association of the ERC. There is the criteria, first of all, of selecting them as showing a potential instructor. They have to be voted by the instructor. There is a checklist to be filled. If they show the criteria, they will go for an essential course for training. Then they have to be monitored successfully for 2 to 3 months courses. They run it individually. Then the first 6 months, they have to run the courses with support of one senior instructor. And they move from phase of instructor candidate to the instructor. So this is the majority pool, but to maintain the quality of those instructors and to make sure that they meet the international criteria, we have to develop our faculty more and more. So we have a training center faculty who are the experts of that. For each discipline, we have at least 8 training center faculty. Means those who can run the instructor courses. They are the one only authorized to renew the instructor after every 2 years. Each instructor has to run a number of courses first, which is 8 courses minimum. After he finished this requirement, he has to be monitored by one senior during 1 or 2 courses before renewal. And then he is providing for the discipline he teaches some skill testing. So to make sure that he provided in a proper way, we have to test him for that skills he's testing.
Sure.
And this is what he follows. We have the right to renew their status. And this is the second line, which are called training center faculty or expert. But we have also course directors who are the top, like educator, and this will be assessed by the senior faculty and through a lot of assessment on ongoing course, and they will be authorized by either the American Heart Association or the European Resuscitation Council when they met the criteria to be as a course director, and they are the one, they can say, oversees all the quality of course and the instructor, and solve the issues and put the plan for the if there's any issues, and also to guide the instructor TCF and the instructor of the course. So we follow the international guideline to maintain the state. Definitely, every year we have people leaving after we develop them. They leave, they resign.
Of
so
course,
we have another in progress and in process training. So we always have a new candidate coming, instructor, promoting them, other going, and it's like that. So we maintain.
So you have a continuous pipeline of developments, and that's how you're able to grow it. Oh, amazing. So
one more thing, because
go ahead.
We've been monitored by the international, like the AHA or ERC. Every 2 to 3 years, they will send someone from other discipline. Like we do go also. We go for other places to make sure they maintain. So I'm a regional faculty. I don't have the right to do monitoring on my side to renew my contract, but I go to other places, and they will send me someone else from Saudi Arabia, from Qatar, from wherever.
So it sounds like there's a really strong culture of quality assurance as well that runs through this, which is great to hear. This is quite a sophisticated, very sophisticated, advanced, developed simulation program.
They will monitor the administrative review, which is how you maintain the filing, how your checklist and everything. That is 1 or 2 days completely. Then there is a course monitoring. They will ask you to run a course, and someone else from outside is observing. And then they will monitor your instructor. So once you successfully finish these 3 steps, you will be awarded that renewal contract, or if not, they will tell you have to review these things. So we follow a solid and a complicated training process to maintain our quality.
Amazing.
I think basically, that's like Boubaker described, we to scale things, like Tony asked, to scale things, we have adopted like a coffee shop chain or fast food chain approach. We have
like a franchise.
Exactly. So we have a very robust system, and it gets replicated. It's all documented in detail, and having one course. This whatever he described also for life support, whether it's American, European, trauma. Also applies to our bespoke in-house programs. So it's a matter of build something at the beginning, tweak it a little bit until it's you're happy with the maturity of that thing, and just keep replicating it again and again. So you end up with the same quality. Plus, like Boubaker very well described it, there will be some deviation from every now and then, and he's running a very tight ship. So making sure that the quality assurance is there. Boubaker brings some of the instructors from the sites to the training center to observe. He mixes the candidates. These are things that tricks of the trade, which is maybe not discussed yet. Things about mixing the candidates, so you would see if they have passed the course in one hospital or one training site, but then they're coming for the second part of the course in training center, and he would assess should they have passed or not. So
interesting.
So you can use this in-situ simulation not just at sort of examining practice readiness in clinic, but also you can use it about testing training quality as well. So that's really interesting. And I think there's a lot that we can learn from this model that you've employed. But what I'm really interested as well to know is, what have you learned about simulation-based education in situ as a result of this process?
We learn a lot. We share the knowledge with our expert, other people when we go, because if you run a scenario, for example, there's a lot of management in cardiac cases, in airway cases, and you have an expert with you who is a very senior consultant there. So also you learn from their daily practices. We learned that we are getting close to the patient. We are helping the people to buy time for them. Actually, we want to close the gap of our concern in the EHS. We provide service for all the patients. And at the and they are coming to our hospitals. So by preventing and identifying the causes of death earlier, so first we are really reducing the number of code blue or cardiac arrest in the hospital. So when we run a simulation about that, we are helping the people to identify earlier signs of deterioration, and then to avoid any patient to go, for example, for hypoxia, hypoglycemia, which are very minor things, but can lead to cardiac arrest. So we do buy time for the patient by our simulation, by letting our people together, we discuss how do we do that. So we do the training, but we do also the assessment at the same time. Sometimes we go for assessment only. We want to run the assessment and how do they do in a real patient. Sometimes we ask, we move very early. The shift here in the UAE is 7 to 7 p.m. Shift. So 7 a.m. usually is an early time to go there. The team of the night is very tired. The early colleague is still not on the mood to start. So we go at 6:45. So to see two teams.
And you don't get that when you do simulation in the simulation center, and you all arrive at 9 or 10 o'clock in the morning. You've all had a good breakfast, and you're ready to. You don't get that realism of what it's like to be at the end of a shift, and yeah.
So we go at that time, and we are able to assess two teams. We are assessing not only in part of our simulation. We don't assess only the management. We assess the communication. We assess the debriefing. How do they debrief or no? Did they improve from their debriefing or no? What they learn from the debriefing? If they are using the debriefing, the hot or cold or warm debriefing, what are the areas they cover? We try to bring to their culture that stop blaming each other during the debriefing. Of you did it good, appreciated by name, and highlighted. The area you did good and needs little bit improvement, so also highlight and see how you correct it. And the area you feel it was the black area, you need to work on it. And we will come back to you after 6 months, 3 months to see how do you improve it. So people.
So it seems to me, that what you're kind of creating there is we all know that as healthcare professionals we should have a positive attitude towards continued professional development. But it seems to me that by doing this, by going out into these clinics and bringing that kind of educational philosophy, bringing that no blame culture, by normalizing this kind of ongoing process of development and reassessment, that it just becomes ingrained in the culture of the EHS. It's a cultural shift,
isn't it?
The culture. It became a culture, and we go to the healthcare provider, the nurses, technician, and doctor. We're getting the request from the CEO of the hospitals. I heard you came today. Please come again and again. We're happy to identify our area of improvement. And most of them, they are very well appreciating, and they don't go for the blaming why the TDC comes to you and you didn't do good. They will not tell them. They tell them, okay, now what impression they give it to you, what notification, what area they ask you to improve, you have to work on it, and they will come. And we'll tell them when you are ready, we will come to you also again. So also we want to monitor the training we give to them here of 2 days.
Of course.
We give them, because we do almost free training, zero cost for our candidates. They don't pay anything. So they come from the duty. They come by hospital transport. They take the material from our side. They get certified from our side. They get CME from our side. So it's time to go and make sure that what they learn, they still maintain it.
Well, that's very reassuring as well for practitioners to know that, that having met a certain standard in a controlled environment, that it's replicable, and assessed against the same standard when they're in clinic. Thank you so much for that, Boubaker. I wonder, Mohamed, what have you learned about simulation-based education in the process?
This has been a huge success for you, clearly. The project that has obviously turned into almost, like we said, a cultural norm now.
Yeah.
So what have you learned, and what guidance would you give to anyone who might be in a similar position?
Absolutely. I'll start with the cultural aspect, like you mentioned. It's the education culture is there. But also, if you think about simulation, the the way you educate a simulation educator. A lot of the behavior you want them to implement or exemplify in their training are behavior in the generic form that you want to see in your healthcare team. You want a no-blame culture. You want respect between the team members. You want people to be giving feedback in a constructive manner to each other. And the more they see it, and I think our advantage is that they have an expert who is leading this, and also they have the healthcare providers, their colleagues, who are also instructors. And that kind of seeps into their daily behavior, as well as they become role models of how they do things and communicate with the rest of the team. This is a useful, let's just say, useful side effect we didn't expect. In terms of administration,
I mean, that is a wonderful unintended outcome, isn't it, of the project? So that's magnificent to hear. Thank you. Sorry to cut in, but we talk a lot about the power of unintended learning outcomes, and that is a phenomenal one. But sorry, I interrupted.
Yes, absolutely. From an administrative perspective, I think there are a few things that we learned. One is you could do in-situ simulation with a relatively low cost. Not the usual expense. I mean, we had quotations of nearly $1 million dirhams, which is like $400,000 in the past, and we managed to do it with much lower than that. As long as you have the team of people who are interested in participation. We also had, I think leadership support was important for the start. We had a lot of engagement with leadership at the beginning of this, and also for the continuation of this. So it doesn't become an activity that's something we did during COVID days, but we no longer do it. No, this is still ongoing.
And when you say leadership, that's clinical leadership, managerial leadership, but also kind of governmental kind of leadership and buy-in. Is that fair to say?
Yeah, I was referring to clinical and administrative. So facilitating things in terms of a budget, staff time, administrative. The clinical leadership is the interest, and sometimes they overlap with the clinicians running hospitals, like Boubaker mentioned, where they noticed it's done somewhere else, it's very successful, and they want to have it replicated in their facility. Some of them wanting to have a report of the performance of their teams, so they can work on improvement there. Like you mentioned, there are issues that are not seen in vitro when you are in the lab simulation. But once you go into their workspaces, the room might be too tight, the door is not optimal, the equipment are not what they had in mind, and these little things that really make a big difference in critical dealing with a critical case. So essentially, that really cost is not an issue with a bit of innovation, and if you get the support, you can do a lot of things. And building the culture, as you said, I think simulation, we were successful to have a good simulation culture before the pandemic, and I think that was a key reason for our success afterwards. If we didn't do any simulation before that, and suddenly we moved with that ambulance, I think we would have faced far more resistance.
Yeah, I'm sure you would. Yeah. It sounds fascinating.
Yeah,
doesn't
it does.
I'm just conscious of time, and I think it's probably a nice sort of segue to start to wrap things up. So, Dr. Mohamed and Boubaker, thank you so much for joining us on the podcast for this episode. It's been fascinating to hear about. It's a huge project.
Yeah, it's been absolutely brilliant. No, thank you both from us here in the UEA over to you in the UAE. It's been absolutely brilliant. Thank you for this insight, really, into what you're doing. And hopefully we'll get you back on a future episode to tell us a bit more about it.
Sure.
So yeah, Boubaker, Mohamed, thank you so much for your time.
Thank you.
Looking forward to seeing you in Sharjah again, Lawrence and Tony. Sure.
Well, as an offer we can't refuse, right?
Yeah, we'll be there.
On the simulation together.
That
Sounds
sounds like
better.
an offer I can't refuse. Gentlemen, thank you so much for your time. And thank you for listening to this episode of SimCast. We hope you've enjoyed it, and we look forward to seeing you on the next one. Bye for now.
Thanks, everyone. Bye-bye.